be the moderator of this session. I will have a short introduction in the beginning, and then I'll give the word to our three eminent speakers. We have a long title, but the point here is artificial intelligence, visualization, and imaging are keywords to what we'll be hearing about in this last session here on EHiN. As I said, I come from the Norwegian Center for E-health Research. We're a national research center located in Tromsø, northern Norway. And we have health analytics, as we call it, as one of our key areas that we work in, very related to this session. This summer we gave out a report on health analytics. It's available on our web pages for those interested. It's supposed to give sort of an overview of health analytics in the health field. It's available as a short Norwegian version and a longer English version for those interested. Medical imaging, as we'll be hearing a lot more about here today, it's a field under rapid development. As we say in the report, it's one of those areas for artificial intelligence where one has come furthest. And it's further advanced in many other areas when we talk about artificial intelligence or machine learning or what we want to call it. In radiology, in pathology, fMRI, and other areas of imaging, one has used medical images and artificial intelligence to provide decision support. It's available for interpretation of images, and image-guided intervention are some of the keywords in this area. I can't go into every detail of this. I will just give a very brief overview of what we're talking about when we talk about artificial intelligence, machine learning, etc. Broadly divided into some key areas. Supervised learning is a very common method, or a set of methods, where one has sort of a ground truth, and you want to learn the machine how to interpret something, whether it's an image or a combination of sources, text sources, etc. But there is some ground truth. Someone has set a ground truth, and used the machine then to replicate that ground truth. So you need a specialist to tell you what is actually the truth. And then unsupervised learning, where you don't have that supervision. You have no one setting a ground truth. You leave it up to the machine itself to provide some sort of knowledge out of the data. Of course, this alleviates the step of having someone to actually tell you what the truth is, which is a labor-intensive task. But also you don't know exactly what you're getting out in this case. And then you have something called reinforcement learning, where you have some sort of reinforcement mechanism that rewards the algorithm towards some kind of target that you specify on beforehand. And you see in all of these there is an output. That's not specified here what that output actually is. It can be, a typical example is that it gives you some kind of decision support, something that you can say to a doctor, well, these are the suggestions of the machine. It's still, no one is replacing the doctor here. It's still up to the medical professional to take that into consideration. Decision support is very often a keyword here. And then we have something that is very hot topic these days, is deep learning. It's actually quite old, because it's neural networks that one was talking about decades ago. But there has been some developments, both in terms of machine capacity, but also in methodology here, where you can have an input image, and then you have these different layers in the network that takes the interpretation stepwise further. You start with the individual pixels, and then you maybe identify some edges, and then you combine those edges until you have some features like an eye or a nose, if it's an image of a dog. And then you combine that, and the machine can tell you that this is a dog, not a cat. There are some caveats here. Machines aren't always perfect. Keep that in mind. This is an example published this year, a team from Google. They took the image on the left, which is a panda. It said that, yes, this is panda, with 57.7% confidence. Then the researcher added some noise. It's very targeted noise. It looks like noise to us, but it's very, very targeted noise. Very subtle. the magnitude is 0.007 compared to the original image, and you get the image on the right, which looks to us identical as the image on the left. The classification algorithm now said that this is a gibbon with 99.3% confidence. We can't always trust these algorithms. You need also it works in different ways than the human brain. Then I'll leave the words to Asta Kristina Håberg from NTNU in Trondheim. She's a professor and Dr. Med. She comes from the Department of Neuroscience and Movement Science at Faculty of Science and Health. Asta.
Thank you for the introduction, and thank you for inviting me. I will present. I think I should have that one. Thank you. I will. Okay, I'll start over again. I will talk a little bit about what we're doing at NTNU with regards to artificial intelligence and how we use it in combination with image diagnostics. And I will mainly show you examples from our activity, but first I will actually tell you a little bit about, first I'll have to come with a disclosure because I'm head of a research-based innovation center, and we collaborate closely with several companies, but I do not get any funding directly. It's only for research, but one of those companies is GE WingMed, who makes cardiac ultrasound machines, and I'm going to show you some examples, and these things that we're producing will of course end up in these scanners in the end. Just to kind of put you into this talk into context, I'll tell you a little bit about radiology. Why has artificial intelligence and radiology and diagnostic imaging become so closely connected? And why do we have such hope for AI in radiology? I will then provide some examples of different things that we do with AI, and then I'll have one slide at the end about future directions. So radiology used to be making an image, printing it on a big piece of photo paper or like translucent paper, and then put it on light boxes, and the radiologist would sit in a dark room by themselves and look at the images, and the clinician would come by. This was the case until like the end of last century. Then everything became digitalized. Radiology was the first clinical specialty to digitalize fully. The way that we obtain the images, the way that we store the images, and the way that we retrieve the images, and the way that the doctors view the images, it's all digitalized. So it is perfect to implement AI in radiology. However, it's not only the way that we do all of these technicalities that has changed in radiology. It's also what we can see and what we can do. This on the very left is the first X-ray in the world. It's Konrad Röntgen's wife's hand. You can see the skeleton or the bone in her fingers. The one in the middle is the first MRI in the world. It's of a finger of Sir Peter Mansfield, and you can only guess it's a finger. And on the right, you can see the high-resolution image of a finger that we can obtain with a strong magnet today, an MRI scanner. And you can see not only the bone in the finger, but all the soft tissues, the tendons and the fat and the cartilage, everything. So there's a resolution and depth to what we can do now that is vastly different from what was possible just in the 80s and 90s. These are some examples coming from how you could kind of deduce that there was something wrong in the brain. You have a X-ray of the skull, and you remove all the water or the cerebrospinal fluid from through the back, and then the areas in the brain that's supposed to be filled with cerebrospinal fluid is filled with air, and it becomes more translucent, And then you can see that there's a black arrow to the left there. There's something that's lifted a little bit up, that's more translucent than on the other side of that skull, and that could indicate that there's something growing from below, and that must be a tumor. So it's very indirect and difficult to understand what was actually happening in the brain. Or similarly on the right, there's a little black dot. It's a calcified part of the middle part of the brain that some people have, and if it was shifted, that could also indicate that there is something wrong on the other side of the brain. It's all very indirect. Now we can see this. We can see all kinds of details. With an MRI scanner, you have a whole laboratory, and it's a whole laboratory in itself. There's all these different scan types that you can obtain that depicts different kinds of structures and physiological properties and pathological changes in the brain. So a tumor patient today could have this image with A being a combination of MRI and PET. And then there are different MRI scans from B to F, displaying different structural features of the tumor. And then you can also measure metabolites with an MRI scanner, which is depicted in H and I. And then you can combine this, for example, with other techniques that requires the radiologist or the MRI technician or a MR physicist to do processing work, and you can display areas of the brain that are important for language or connections in the brain that you don't want to have to ruin while in the surgery. And you need to combine all of this together to make the best plan for the patient. How are we going to remove the tumor? How are we going to enter into the brain? Which parts are the most important parts to resect? All of these things have to be put together. So it's a lot of technical work, of course, just obtaining this, but there's also a lot of intellectual work in how you're putting all this information together. So today we have all these images, and we have far too few radiologists. Actually, there's a world shortage on radiologists. It's in the UK they used £170 million last year to pay extra for reading images that the radiologists at the NIH-paid hospitals were not able to read. So in the US, they have calculated that, or estimated that there's going to be more than 10,000. There are going to be more than 10,000 diagnostic radiologists short in 2022. So there's a lot to do and too few people to do it, and that's why we're so interested in artificial intelligence. And of course, this is coupled with more people getting older, and older people get sicker. We have more people with chronic diseases that require repeated follow-ups. We have more diseases that can be treated, so more people are getting diagnostic procedures while being treated to monitor treatment. Yeah. So how can we help read all this information and use all this information that we're getting? And maybe AI or other types of computerized help can be a way of improving patient care and reading time, and use all this information that we are getting from imaging in a better way. So, of course, the hopes is that with these methods, we're going to increase productivity, be more accurate, reduce the number of misdiagnoses, and improve patient outcome. Well, I guess I'll need to say that it remains to be proven that we're going to be able to do all of these, though, because we want humans, the radiologists, and we want machines to be accurate. We want them to each time they're assessing an image, we want them to assess it in the same way. So it's kind of like at the bottom there with all the dots together. but we also want them to hit the bullseye every time. We want them to give patients that have a diagnosis, the correct diagnosis, and those that are healthy will have to be ascribed to the healthy category. But it does vary what we can accept. Usually in medicine we have a very low acceptance for making errors, but maybe we can, for some conditions, we can be a little bit more forgiving. I'm going to show you first two examples that's not from our work, just because they were recently published, and there's been a lot about these cases in the clinic, and they kind of show, they are pretty good examples of what we could expect. So the first is a study from China, where they have, of course, thousands of patients, not Korea, thousands of patients, 100,000 of patients, and they suffer from liver fibrosis, which is the liver cells is replaced by scar tissue. And there are different degrees of fibrosis. So those three pictures there actually depicts three different types of fibrosis. It's not easy to see that there's much of a difference. So coupled in these patients, they have taken out a piece of the liver and done a pathological assessment, and from that you get a degree of fibrosis. And then, as the previous speaker said, the algorithm has learned from looking at from getting this information from the pathologist whether the fibrosis is degree 1 or 1 to 4. It has learned to assess these images and say what stage of liver fibrosis they're in. And it was doing a pretty good job. The machine, or the AI, is the red line. So it's always better than the radiologist. The radiologists are the different black lines. But you can also see that there is one radiologist who's always much better than the others, which is also my experience, that there are always someone who's a much better radiologist. It shows that it is possible to use AI to diagnose the stage of the liver fibrosis better than the average radiologist. But there are differences, and the more severe fibrosis, the more difficult it was for the machine to make a correct diagnosis. This is another recently published paper on pneumonia, which is really common, so it should be really convenient just to have a machine that could determine whether someone had pneumonia or not. It's on 158,000 chest x-rays from 3 hospitals in the US. And what they show is that the AI is really good at picking out where the scan was obtained. It's not as good as picking out whether you had pneumonia. And that's not what we want. I mean, we want them to not tell us what hospital you're in, but tell us what's the matter with you. And that shows that it shows something that we worked on a lot is image harmonization. How will we obtain similar image quality across Norway, so that we have a patient can be scanned in any location, and a doctor can read it, and it will have the same quality. And this points in the same direction, that we really need to work in image harmonization if we're going to implement AI in Norwegian hospitals. Now we're turning to some of the work that we're doing. One of them is traumatic brain injury. If you've been like in a car accident or fallen off a roof, for example, your brain is shook inside the skull, and it's not very good for your brain. And due to the way that the brain is on top and then the brainstem is in the middle, all the kind of forces come down into the brainstem. And you get like typical types of lesions. And we've shown in previous publications that these lesions, their location and the volume of the lesion and the type of lesions together can predict your outcome. And it's good to know as soon as possible your outcome, because then you can put people into the right rehabilitation program. But it's very labor intensive if you're going to count where all the black dots are and mark them on an image, and if you're going to do the same with the white spots. So it would be great if we could have a program that could do that for us. So we're working in this EU project on doing that. It's very hard for you to see because the image is very small, but it's an automated program that actually recognizes these white dots, and it tells us where they're located and what type the program thinks it is. It can be, because when you get older you also get some white spots in your brain. So this is kind of trained to differentiate between those that are thought to be there because you're an older individual and those that are considered to be due to the brain injury. And then you get their localization and their volume. And the same for the black dots. You have the radiologist have marked the black dots on the left, and then the computer, and then you have the overlap. And it works pretty well. So with these programs together, the results of these two image features together, we now hope that we can better predict outcome in brain injury patients. And it's not doing as well, this program with counting the dots and localizing them is not doing as well as the previous that we saw on the liver staging, for example. But maybe if we have more images and we train this a little bit more, that blue dotted line will move towards the left and be straighter, which is what we want. But we can also use AI to help procedures. This is an example from ultrasound guidance of blocking the nerve down your leg. So you have the ultrasound probe here in the groin, and then the ultrasound probe, then the program and the software recognizes where the vessels are, because anesthesiologists don't want to inject into the vessel. It wants to inject into the yellow nerve there. So then the anesthesiologist can actually guide how they inject, and that they are injecting into the right place. So this is another way that AI can help. It can help us do procedures in a different and safer and more efficient manner, and which is especially important for the more junior staff at a hospital. This is another application that we're working on, and that is for automatic extraction of lymph nodes. If you have, this is a CT taken across the thorax like here, and if you have a lung tumor, you will most likely also have metastasis in the lymph nodes here in the middle. But it's really important that there are very many lymph nodes. It's all of those gray on the upper left hand corner in that 4-part picture. So lots of lymph nodes. So you need to figure out which lymph nodes are you going to take a sample from, because depending on the results of that, you can be, you will receive different types of therapy. So we're hoping that with this method and trying to identify which are the most suspicious lymph node automatically, and then guide the person doing the biopsy to taking biopsy of the most suspicious lymph nodes, we can give better cancer treatment. And this is another example. This is how to enable non-expert users, how to make a GP a cardiologist. The movie on the right is a movie of the beating heart. So the tip of the heart is on the top, and so the tip is on the top, and the top of the heart is at the bottom of the image. And you can see that there are some white things in the middle moving up and down. Those are the heart valves. Are you with me? Mm-hmm. Yeah. And then there are some typical images that the radiologist will take because it tells him about the condition of the heart. So the first thing that we taught this program was how to identify these planes that it's supposed to, that the cardiologist is supposed to identify and visualize and make some, do some calculations based on, which will tell him or her something about the heart's condition. And as we were talking about before, we want things to be as we want the machine to perform well, so we're happy when we see that it's able to perform at like a 98, 97 range. It's performing really well, identifying these different views. Then we made this a training program so that you can, a person in the white, it says what it should look like, and then you move the ultrasound probe until it looks like on the image, and when you have obtained the correct view, it says that you're correct, and then it moves on and teaches you something new. So it teaches you these 4 things that you need to know. And then you can, let's see here. So these are 2 people starting at the same time. And the experienced cardiologist is candidate number 1. So you can see that candidate number 1 is much faster than candidate number 2. So he used like 21 seconds and he was done. But it's hard when you don't have the proper training. So he's lagging behind. Now they're both done. And then after teaching, after making this, making it possible for the ultrasound scanner to tell to teach anyone how to do a proper ultrascan of the heart, the next step was to use AI to delineate important structures in the heart. So number 1, there's a green line which delineates where the cardiac wall, the black inside is the blood, and then it delineates where the muscle of the heart is. And then, so the program could do that successfully, and it could also determine where the valves are. It's not indicated on this image. And then you could put that into a handheld ultrascanner, which is costs about 14,000 kroners, and you can have it in every GP office. And then the general practitioner can take these images, which it's not a movie on this one. It just shows that he's able to, he or she is able to do this, determined by positioning the probe right. The program is able to determine these values, and it tells, gives you a number, and that number tells you something about the degree of heart failure. And then you can either say that this patient is so sick I can't do anything about it, I need to send it to a proper cardiologist, or I know what I should do about this, what kind of drugs I could give it to improve the heart function. So that is another one. And then we can are of course also interested in predicting outcome. This is an example from brain. Depression in older people is supposed to, if you never had a depression before, it might be a sign of early Alzheimer's disease. So this is in people who came in with depression when they were 65 years and older, following them for a year and seeing who turned out to get dementia. Based on just that one MRI image, it's possible to predict that with 76% accuracy. Not very impressive. But if you add some other clinical information, for example, how well they do on memory tests, you're getting to 81% accuracy, a little bit better. But if you are not just saying that they're demented, but saying that they're not demented, but they're just having a cognitive impairment, which is a different diagnosis, it's actually improving a little bit. So this shows that we need perhaps a combination of imaging data and clinical data, and we need to be very precise with what are the questions that we're asking the artificial intelligence to answer. So it is, AI can perform tasks better than the radiologist, and it can also teach you how to do things. And, but we need to be precise what we're asking the artificial intelligence. We need to it can only answer what we ask them to answer. So if we put in the wrong information, we'll crap in, crap out. And we need to be work on getting data that we can actually that will perform in a similar manner in the same algorithms. And we need someone to supervise the activity. And in Norway, with public healthcare, we have an excellent opportunity to try out artificial intelligence on lots of data, but someone needs to quality assure the data that we're putting in. And we also need to collect it in a good way in the future. Thank you.
Thank you, Asta. Any questions from the room? Crystal clear.
My name is Petter Østberg. I work for Sikkerhet. There are large archives in Norway considering or having radiology images. How do you see the opportunity to use all of them to analyze with artificial intelligence to find structures and diseases, trends in society, considering that you said that we have to harmonize how we do the examinations, what the images look like?
I think that we don't really know in Norway yet. We have a lot of good equipment in Norway when it comes to radiology. I think that for some investigations, like just chest x-rays, maybe we will be better off than the US. But I work mainly in brain MRI, and my experience is that that is vastly different across hospitals. And I think that there could be problems due to lack of similarities in how things are scanned, using them to, for example, predict certain conditions. And I also think that, for example, when you do ultrasound, you only pick some slices that you depict, and then you put that in the archive. While you could actually, in theory, store the whole examination. And I think maybe some of, if we've done things a little bit different, maybe we'll have a richer data set that would be easier to use.
Okay, I think we have to move on, but thank you very much, Asta. Our next speaker is Kyrre Eg-Emblem from Oslo University Hospital. He's a principal investigator at the Emergency and Critical Care at the Intervention Center.
Ja, So thank you for the introduction. I'll stay with brain, but we'll move into cancer. So that's the focus on my talk, and try to see how we can use sort of a computer diagnostics to aid treatment in cancer. Really, sort of the focus of my talk is that I'll try to dig down and go under the hood of really what's sort of out there in terms of what's available today in what we actually face when we meet these patients, and then we'll go to some potential applications for AI in these patient groups, and then I'll end by showing you a few examples. I hope you're with me. So really, sort of, as imaging people with this disease, really what we want to do in terms of a therapy and cancer is really identify what the drug is doing to the patient. We want to understand if it's working, we want to know how it works, and in what patient it actually works. Because treating a group of patients with the same drug is not the same as treating every single patient with the same sort of outcome. So we need to identify sort of what's going on in terms of imaging perspective. And our take is that you can't really do a tissue sample, a blood sample of the patient every time, but you could do a blood sample, not a tissue sample, but you could do an imaging over time. So I'm not sure if you're familiar with the setup for a typical clinical trial, but the way this actually works is that you measure whatever objects that representative of the disease in sort of a very crude measure. So you're left with the image you see on your right, which is basically a two-dimensional slice of the image of the disease. That can be some sort of a lesion. And basically you measure the long axis and the short axis of that lesion in a two-dimensional slice. And you use this to derive some sort of measure of size. And more or less that's your status for the disease. You add clinical parameters, but at the end of the day, sort of for many clinical trials in cancer, this is what you're left with. And there's definitely issues to this. You had your lunch, but I hope you can bear with me. This is a brain and a brain tumor, and as you can appreciate, sort of identifying a three-dimensional object on a two-dimensional slice will be suboptimal. You can't really represent the whole image. So basically, the whole disease. So basically, you need a better assessment of what's going on with the disease. And the issue with that is when you go into these late clinical phase trials, you see in as many as 50% of the patients, the decision on whether or not that patient is left on study is based on these crude radiological criteria. So you can have patients continue on trial that should be left out, and the other way around, simply because you're not doing the image optimally. We know about this, but sort of this is at the minimum, because we need something that works for all hospitals, all patient groups. But really, the big thing, and Asta alluded to this, is that we, in recent years, really moved from just looking at a few sets of data to immense amounts of data that you as a single individual can't really comprehend. It's not possible for a radiologist to be on top of this. So just to give you a few numbers, what used to be a clinical scan could be maybe images for MRI in the order of maybe 100 images. We moved to thousands, now we're maybe in the tens of thousands of images per patient, and just the size of these data is just immense. For any human being, you can't really expect this person, even as an expert, to be on top of this. And there's also data to support that you can split the way the radiologist works in these 4 different categories. So you have your detection phase, actually detecting the disease on the images. You measure it, and then you try to set a diagnosis, and you write a report. And people who have investigated sort of the time spent on these different topics, also different phases of their work, show that they spend as much as 80% of the time on the first 2 But really, what they might want to or should spend their time on is setting the diagnosis. So anything you can do to help sort of pick up speed on those two first will be a major advantage to the field of radiology. And really, sort of, I'm a researcher, so from my perspective, sort of, I think this is really sort of interesting and really tells you the complexity of this. The example I'm showing you is a study where they had 5 patients with brain cancer, and they did multiple biopsies of that every single patient. They did as many as 40 biopsies per patient. And then they went to pathology and looked at those tissue samples. And they ended up in some of the patients with as many as 40 different subcategories. So a single patient all had the same disease known as the glioblastoma, which is a certain type of brain tumors. But they had, depending on where you choose your target for your tissue sample, it was a completely different disease. And you can't really appreciate that with a single biopsy. So you need something that can sort of tell you the full complexity of this disease. So we're left with images. And I think sort of that really sort of meets that criteria, because depending on the resolution, obviously, but you're able to appreciate sort of the complexity and the heterogeneity of these tumors. And you can't really read it, but on the right, that's just basically just a score sheet of what is known as radiomics. And basically, that's just different combinations of imaging parameters of the disease for an individual patient. And you can, it just shows you the landscape and the complexity of this disease. So it just adds to the content of this being, the size of the data is just immense. Okay, so is there any use for AI in all of this? I'll just start by showing this as sort of a short reflection. We're looking at projections in a few years that this will sort of be a billion-dollar industry of companies trying to adapt to this new environment in using artificial intelligence to boost the radiological performance. And just a sort of a side note, for those of you who know RSNA, which is sort of this big imaging conference in North America, a few years ago there was like 10 sessions on AI, and it was at the back of the venue at the end of the day, and we were maybe 5 people there. But nowadays it's the focus of the whole thing. It just shows you the rapid speed of this thing and how it's evolving, and I think it's quite fascinating. So why is this sort of interesting to imaging? As Asta mentioned, you have these inherent variations within the setup and how you do your imaging. It might depend on all these things. You typically administer some sort of an agent, a tracer, to get sort of boost your image quality. And depending on how you set your images, how you tweak and turn your parameters, you get a different image. And all of these add to the variability of the image. So if you as a single individual try to make any sense of this landscape, it's very hard. So if we just do a simple test, on your left you have 2 different groups of, we can refer to them as patients. And just simply because of this variation, it's very hard to draw a straight line and sort of separating these 2 patient groups. But if you were to have some sort of a magic pen that you can sort of delineate the 2 groups in a more sort of non-linear fashion, that would be really helpful. And do we have this tool? Well, yes, we do. And this is sort of where machine learning can take us. Now, I refer to machine learning in sort of the classic sense. So this being some sort of a structured, guided procedure, where basically you label something, so you know what's left and what's right, what's up, what's down, what's big, what's small, and so on. And you have the machine, using these conventional methods, try and identify this landscape. And this is what you see in the image and sort of in the movie. And it's quite fast, as sort of a general term. It can handle large and complex data sets. most methods with machine learning, and sort of we used to refer to it as self-learning. You have to be a bit careful with that, but basically it just tells you if you add more data, it improves. And as you continuously add more data and you sort of labeled it, then your model gets better, presumably. And the way we use it is on the right, where I've sort of labeled two different classes. It can be a distribution of data. Anything is shown as red and blue. And sort of when the next patient come in, this tool, this method will use what they know to try and label the new data to a certain category. So basically a new patient comes in with a set of parameters. We have the old method that compares this new set of data to the old data that we know the outcome, and we try to stratify. That's basically the concept. So moving on, another example, and this it's a bit unfair, but I'll use it as just to prove a point. This is 4 radiologists asked to delineate the same tumor. So again, it's a bit unfair, but sort of what this represents, the different colors represent different radiologists and how they define the region of the disease, the outline of the disease. Now, it doesn't tell the full story, but it just shows you, just for a simple image, it's very hard to have expert readers identify the same region. They will do it very consistently over time, but just doing it sort of have them match their image is quite hard. Whereas the next level would be something like this. This is sort of the classic way to do image segmentation, where you start off with multiple sets of data. That's your whole input, your whole exam, and you clean it just to make it easier to process. And then you have some sort of a segmentation routine, which is shown on the third image. It can be supervised or unsupervised, as we heard. And then you have add that to some prior knowledge. You know something about what to look for. And that's sort of the classic setup. And you get this region of the disease. And sort of comparing that to manual outlining, at least what you gain is that you can have the machine do the exact same thing every time, how wrong it may be. We'll get to that. So where we're at the moment, and we briefly touched on this with the previous speakers, is sort of we moved into what is known as deep learning. The example I'm showing you is what is known as convolutional neural networking, which is basically a method, but instead of doing a single sort of machine learning algorithm, you have multiple layers, and that hence makes it deep. And by that, you don't have to sort of inform the system on what to look for. So there's a few advantages to this. You still have to do your pre-processing and sort of label and set your data, but at the end of the day, you can have something that sort of, you don't need to know what to look for in the images. So you can let the computer, just by doing these multiple layers, identify the structures that's unique to your label. And this setup I showed you is good for images. There are other setups. This is known as a UNet. Again, sort of another topic, sort of another tool that's good for medical data. And basically what we're looking for in medical data is, unlike pictures of cats and dogs, usually for us, like a patient group, we don't have tens of thousands of data. Maybe we have 100 patients. So we don't have that many patients, but so we're left with something that's both fast and need to work for sort of lower-ish sample sizes, and this method will work to that end. So I'll just end by showing you examples of those. First off, if there's anything to be sort of proud of in this field, is that this actually goes back 10 years. And this was something we published 10 years ago, just using a simple machine learning tool. But it was made a method that was set to identify brain tumors, either a high grade, a sort of a malignant one, or a low grade, a sort of a more benign one. And we compared that to expert readers, radiologists, and it did as good a job. And then we did this again a few years ago, looking at survival data, looking at the distribution, or you see on the image, that's the distribution of different imaging parameters. And we asked the model to try and make the best prediction for overall survival. And again, using multiple centers, data from multiple institutions, it beat observers. It basically did a better job by identifying patients with a short or long survival. Now, I don't say that's the best use for it, but at least it can help you guide therapy along the way. That's sort of where we're left with. Another topic for this is tumor segmentation. I showed you an example, but the good thing about this is that you don't need to know all those features. You don't need to guide the system along the way. And this has really exploded in the last few years. This was using the method I showed you with the convolutional neural networking. And this is just some data that a postdoc of mine is doing at Stanford at the moment, where he identified brain metastases in the brain. That's very hard because metastases can be very small, and doing that, he does that with excellent scores. So I think that's sort of, it's still in the making, but I think it has potential. I'll leave you with the last example, and this is basically combining that information from the survival data I showed you with this segmentation. So you have a start to end automatic method. Basically, you just chunk it in the computer, you press play, and then you end up with result. This is also still in the making, but I think at the end of the day, it will help you guide your decision making and maybe move things from going from that 80% detection measurement phase into your reporting phase, which is really probably where you want to be. So I'll end things with this. Asta showed maybe the first MRI image. This is claimed to be the first clinical MRI. And just to give you a perspective of the history, this was done in 1977. And I'll leave you to decide if this is true, but at the time it was considered, as you can read on right, a fantastic success. First human image completing amazing detail. So at least it gives you a bit perspective where we are at the moment. And it's still a long way to go. So thank you.
Thank you, Kida. Fascinating overview. Many questions from the room?
I have one, if that's okay.
Okay.
I would like to thank you and also Asta for a very good presentation of applications that we hopefully can get into production as soon as possible. I mean, tumor working with cancer is really time consuming for the users out there, the radiologists. And there is sort of a distance between what, of course, you're doing and getting this out into production. And how do you see the next steps to be able to get this into production? That's the questions we get from the other vendors as well. When does this help me in my daily work as a radiologist? Well, I know it's a not funny question, but...
Yeah, I think maybe it's partly the answer to that can be seen at these conferences. So if you go to any of these radiological conferences today, there's one at the end of the month, is RSNA. You will see just a boost of companies doing this. At one point, they will be picked up by the bigger vendors, and then it will be set as a sort of a third-end product to the bigger vendors who are also available at the hospital. So using this as sort of an addition to your clinical routine is not that far off. But using the best method is still sort of an open question. But it's starting to get there. You have issues with like GDPR in terms of patient ethics and so on. But it's moving in the right direction. So I'm pretty optimistic.
Can I have a follow-up on that?
Sure.
Don't know your time.
Sure.
I think that's great, and yes, I'm going there as well to RSNA, of course. But we do this in Norway. I mean, you're doing great stuff, and it would be nice to see this commercialized as Norwegian solutions onto the international vendors platforms that are working with the radiologists? And that's a challenging question as well. Do you see how could we move into commercialization of what you guys are doing, getting into production? Okay, there's a...
You need a center of research-based innovation, not only with ultrasound, but with images, all images.
Mm-hmm.
Amen. For those who didn't hear, we need a research-based center for innovation on this topic. We are a bit short of time, but if you have a short question, that's okay.
You had one of you, in terms of older people, depression, and as predefined for Alzheimer. What are you doing for the kids with narcolepsy, with ADHD, and so forth? You know, with the neurodevelopmental disorders or conditions. Have you anything to tell us about that?
We are doing a lot with kids. It's also part of the mother-child cohort. We have imaged those kids that have been followed since they were in their mother's womb. So I think that there will be, there are also a lot of potentials there.
Okay, we have to move on to the last speaker. Renate Grüner. Oh, thank you again, Kira. Our last speaker is Renate Grüner. She's a center leader at the Moon Medical Imaging and Visualization Center at Haukeland University Hospital and University of Bergen. Welcome.
Thank you. Can you hear me okay? Okay, thank you so much for being invited and also for giving me the opportunity to present some of our work. I will talk about imaging, about artificial intelligence, and about visualization, and try and combine it, given that the task of this session was to sort of look into faster imaging, or how we should accomplish something like this. So a year ago we started out a new research center in Bergen known as the Moon Medical Imaging and Visualization Center, and some of our core activities is to move into new ways of acquiring image data. So we look at new biomarkers, not just the conventional structural data, but also go into the depth of the physiology and maybe the biochemistry of matters. We do feature extraction, so we do statistical, mathematical, and physical modeling of the data to see if we can extract parameters like blood flow and blood volume. But also we want to combine it with all kinds of omics data, both genetics but also molecular information, into doing longitudinal follow-up in patients and imaging, combining imaging with other types of data to maybe come to the goal of predicting disease outcome or patient outcome. We are very much, although the center has 3 faculties involved, so the psychology faculty, natural science, and medical faculty, we are very much into the department of radiology. And our department performs about 400,000 examinations per year. And if you think of each patient generating between 1 and 25,000 images, it's quite a lot of data material that is acquired every day that goes into these common PACS systems. We also have a parallel research PACS system, because there is some difference between what you acquire in a research phase compared to conventional imaging. And we have some infrastructure, both on the university side and in the hospital side, ERRS, infrastructure as a service, or the SAFE system in the university, which we can use for data handling and processing. Here is our news computer. This is in practice what it is. Our imaging equipment is simply something more in our chain of processing data. This is just a few days old PET MR that was delivered to the hospital. Of course, it's a very heavy computer, in all aspects of the world heavy. The way our radiologists work is that they do differential diagnostics. So they acquire images and then they do almost like a mental arithmetic on how the image contrast changes among the various images that they have available. So they can, from this, decide on whether it's what kind of type of pathology it is. It's typically quite qualitative in its approach, but it's very, very individual follow-up of each individual patient. So you go through the PACS system and simply collect previous examinations, and you can see how the disease has developed over time. So they have an excellent follow-up, and they have all the medical patient history and medicinal history available at the time of reading, so I think the system works very nicely. Of course, it has its shortcomings, because in principle what we would like to do is to be able to omit any biopsy, so that we could in principle say that every biopsy is an imaging failure. We want our imaging technologies to be at such an accuracy that we don't have to do these biopsies, with all the diversions that are involved here. Also, we know that there is a lot of new drugs coming, both pharmaceutical drugs, anti-cancer drugs, but also now at 2 sites in Norway we're building up particle therapy units, which really require the precision of imaging that we don't haven't experienced before or to date. So we really have to move our imaging in that direction as well. And what we see is that we have different patient groups coming to our scanners now compared to previously. Many psychiatric disorders have subtle disease processes which we can't pick up with the bare eye, but we need our mathematical tools to really pick up both the disease, maybe understand the origin of the disease, rather than the way we approach images today. And this is sort of the difference between what we do in the clinical radiology and what we do research-wise. Research-wise, we've come out with a battery of approaches to do imaging. And so what I would like to focus on a little bit today is how we can make these two worlds meet. So the individual world of the radiology, but also the group analysis and cross-sectional studies which the research typically has. Then you have a method, and you have a patient group A versus patient group B, and then you make a cross-sectional understanding of, or inference on what's going on. So in principle, we would like our clinical way of being a little bit more quantitative, and at the same time our research approach becomes maybe a little bit more individualized. Here is an example of things that we do. For instance, we can study the brain on how it solves various tasks. If I read red, yellow, green, blue, that's not very difficult for me. I can get a statistical map, the upper row showing which part of the brain that is involved in solving that task. If I were to say the colors instead of the word, and I've tried this so many times and I always fail, but if I say blue, red, white, blue, yeah, there's a conflict going on, and we can make statistical differences. Now it's a much more difficult task for my brain, because it's simply so trained on doing the reading instead. We can use that to study a cross-sectional in a group of schizophrenia. Here is a professor in Bergen, Professor Kenneth Hugdal, who has an ERC advanced grant, a second one also, on studying auditory hallucination. Then he doesn't really just say that we have group A versus group B, but he says, let's go for one symptom in the category of schizophrenia, auditory hallucinations, and we map that to a group, and then we do our comparison, and he can see where sound, or the perception of sound, originates in the brain. Another researcher in Bergen is looking at the effects of electroshock therapy, electroconvulsive therapy. And the sample in Bergen, it was fairly sparse. It's only 19 participants, and at that stage he's decided to ask for international collaborators, and he has then received, has now the input from 15 different sites, and 7 more are to come. And suddenly the sample size goes from 19 up to 550, and then you can start to infer on the statistics of this. So it's a way of grouping data. Yeah. So we can acquire structural data, various levels of data, but for instance, doing the upper row structural data, segmenting it into the brain into various, like 133 smaller volumes, and then maybe you can have one patient and see how does a certain volume change compared to the average population. You can say something about whether it's abnormal aging or not, or you can extract other parameters as well. So we can in that way make our imaging methods more quantitative and maybe also more individually. I have to pass this a little bit faster than I had planned. But if we can in principle now from our imaging methods that we use in research-wise also infer on things that go down to genetic expression level. Like for instance in brain tumors we can measure the biochemical concentration of various metabolites in the tumors. And if we look at a marker known as 2HG, we can suddenly pick up potential genetic mutations which can say something about the prognosis of the patients, even on the single individual level. So imaging is sort of pushing us downwards to a resolution which imaging alone isn't really able to achieve. So some of our research projects have sort of this approach where we are collecting various kinds of biomarkers, various kinds of imaging, but also genetic information, molecular information, preclinical studies, so avatar models. And then we use this to stratify the patients rather than having the groups predefined in beforehand. And so here we have a project on gynecological cancers. And what we can see in these is that we, in a group of, say, 600 female cancer patients, we can now distinguish the group into more aggressive, less aggressive, and more benign types of cancers, and we can make the treatment follow-up also much more suitable for the right patient category. And in this specific case, it is parameters when the tumor has low blood flow, we can actually see that there is a more aggressive type, usually it's the other way around, and that we can see gene expression for hypoxia at this level. So it's really going down into the genetic information, even only from the imaging data. This also goes from where we have fat, so if we have much intra-abdominal fat, we have downregulation of the inflammatory of our immune system, which makes it actually more, we have a better prognosis in cancer if we had more bowel fat compared. So the fat distribution also actually determines the gene expression that we have available. So this is imaging information that we have. So anything you can do, I can do better. When we do all this advanced imaging, we end up with so complex data. We can do correlation up and down, and we have to have somebody to draw our region of interest, for instance. It's very time-consuming, and it always ends up in the research phase, and it's more difficult to get it into the clinic. So one of the core applications of IE will be probably to automatically deline the lesions that you're interested in. And if you achieve that, you can automatically read out all the parameters that I was just describing, which could be tremendously useful. IE has been around for quite some time, but the reason why it's becoming so extremely popular, and that I think is really exciting, is that it has such an open science approach. Both the analysis tools and also large databases are becoming available, so everybody can start to test out their methods, and this is really making it flourish a lot more than if everybody was sitting on their own data. So this, and of course, big companies are making huge investments to make this move forward. We also did some machine learning 10 years ago, and some researchers in our group actually 10, maybe 15 years before that again, to segment out brain structures, but that was more based on conventional machine learning approaches like support vector machines or k-nearest neighbors approaches. And now, of course, the big thing is deep learning and neural networks, and it's been applied a lot in imaging, and not necessarily medical imaging, but a lot of the technology of these convolutional neural networks has been developed on images. What we are working a lot on is, and that's with Professor Arvid and Alexander Lundervold, is to apply the approach to medical images. And because it's such a generic approach, it really has a lot of different applications, ranging from segmentation of brain tumors, studying networks in the brain, segmenting kidneys, predicting structures in vivo, detecting action down in the right side, And so the same approach can really be used for a lot of different approaches. And here, for instance, I mentioned before that you could do brain segmentation into various regions, and that would, with the conventional methods today, take like 6 or 7 hours. These segmentations are done in 10 seconds with this approach. And if it's that fast, then it can actually be implemented in the clinic as well. So it's something about speeding up things that we haven't been able to do before, and then it's more easy to make it available in the regular, everyday clinic also. And because we are now training the data on MR data, for instance, it's even easier to use it on different applications which also are MR data, because you sort of incorporate the learning of MRI in the MR data. So these are examples from ongoing projects that we have in Bergen these days. And we've been at the RCN, so the Research Council's booth all day, and the students are still there. So if you want to talk to some of our ongoing active, excellent students in the field, then please do so. I hope they're still around for a few minutes after this session as well. Yes, this can. My final 3 minutes I will use on medical visualization, which is also an important branch, because some of the sort of shortcomings of IE has been on that it's a little bit the black box, and you get out with a result which might be difficult to interpret or grasp or present. And medical visualization, that is a branch which has not only the purpose of making pretty images, but actually to provide insight in the images that are given. So you come from basic data or from model data, and then you can show something which, so you use the brain perception to show something which is not simply a geometric representation of what was already there. And one of our excellent researchers is Nuska Schmidt. She has had a project on rectal cancer where she has been trying to visualize almost invisible nerves that are very subtle to be surgically damaged during a rectal cancer resection. So she has made, based on like histological cryosectional slices, a model of what these nerves would look like, and then applied this model to the regular patient so that the surgeons would have this information in time before performing the surgery. Yes, and applying them in different patients would then provide information so that potentially the complications post-surgery would then be less. The tool is also, of course, very intuitive for educational purposes, and that has already been used in a workshop for 18,000 users worldwide. So it's something about presenting and communicating in the field of medical visualization, which we maybe have ignored a little bit. I think it's a useful tool to complement machine learning approaches and regular imaging in how we communicate our research. Other researchers in the field, Stefan Bruckner, is using it a lot for three-dimensional visualization, stretching out vessels, making group comparison. It's something about how we can communicate back to our patients, maybe prior to a surgery, show them what the sort of angle of surgery would be, or what the disease really is. Maybe combined with illustrative visualization, so that you sort of make a model around the data that are partly realistic and partly then illustrative. Or to describe things like flow, here from Professor Helvig Hauser, also in Bergen. Or you can do higher dimensional data visualization, which could be a talk in its own, and I'm afraid I won't have time to go into. So in summary, I think bridging the gap between our clinical imaging work and the research imaging work is highly feasible, and in the combination of imaging and machine learning and visualization, I think we will surely come there. It's something about e-infrastructure and ethical aspects and safety aspects that needs to be discussed, but this is sort of the area that we're working in, and I think it will change a lot during the next coming years. So thank you for your attention.
Thank you, Renate. Any questions from the room? No?
Just a short one then, since no one else is asking.
We hadn't agreed on this.
Yes, again, very good, and very interesting, and so tremendously big potentials in imaging when it comes to healthcare, putting the right diagnosis on the patient at the first try and straight to the right treatment. That's what we want. There's lots of radiology imaging here. You had some movement examples. Do you have any from, I mean, skin? Someone, I mean, not radiology, and perhaps you could elaborate a little bit on what you're doing more outside of radiology.
So personally, I work only in radiology imaging or in medical imaging. But surely there might be people in our group who are working on cell imaging, at least. Are there skin images in there as well? Yes, Alexander, do you want to comment on this, or?
There's not much more to say that we have looked at the skin classification of that from some unique data sets.
Yeah, so skin lesion and classifications. Thank you.
All right, I think we have to conclude this session in 8 minutes. There will be a closing session out in the main hall. So thank you for now.